diabetes management in elderly Part 3.
So I'll be talking about diabetes in older adults. So again, diabetes in elderly checklist includes the assessment. So assessment for level of functional dependency, that's frailty. And again, individualizing their glycemic targets based on the HbA1c, so less than 8.5 if it's a frail elderly patient. अगर 70 साल का कोई adult है या 75, 78 का 80 years का कोई adult है, and if he has comorbidities, cardiac comorbidities, renal comorbidities, कोई और comorbidity है जिसकी वजह से उसके hypoglycemia में जाने के chances ज़्यादा हैं, then even if we achieve the HbA1c around 8.5 and sustain it, it is absolutely fine. There's no problem. Again, avoid hypoglycemia and cognitive impairment. Select anti-hyperglycemic therapies carefully. So again, caution should always be with sulfonylurea and TZDs. Why TZDs? Anyone? Thiazolidine टर्न्स के लिए क्यों करना पड़ता है? Anyone? Anyone?
Fluid overload.
Correct. So fluid overload. So elderly patients are more prone to get fluid overload, renal function depletions. So again, any drug which can cause fluid overload should always be given with a pinch of salt, or probably, it should be given cautiously. Now, again, DPP-4 inhibitor should be used over sulfonylureas. The primary drug of choice should be DPP-4 inhibitors in all circumstances. I believe. However, गाइडलाइंस अभी भी मेटफॉर्मिन बोलती हैं, बट मेटफॉर्मिन से भी कई कुछ ट्रेस केसेस के अंदर हाइपोग्लाइसीमिया होता है, DPP-4 से जनरली नहीं होता है. सो सेफ ड्रग्स होती हैं. बेसन analogs instead of NPH or human 30-70. Why? Because NPH gives a peak at 12, works for 12 hours, gives a peak in between, so उससे कई बार हाइपोग्लाइसीमिया हो जाता है. 30-70 अगेन वही NPH और शॉर्ट एक्टिंग का कॉम्बिनेशन है रेगुलर का, सो अगेन इसीलिए हाइपोग्लाइसीमिया के चांसेस ज्यादा हैं. तो कोई भी मेडिसिन, कोई भी ट्रीटमेंट जो इन पेशेंट्स में हाइपो करेगा, वो पेशेंट या तो तुम्हारी जान ले लेगा या अपनी जान गवा देगा. सो इसलिए मत दो, राइट? Give regular diets instead of diabetic diets or nutritional formulas in nursing home. So again, regular diet का मतलब है normal खाना दो, हर 2-2 घंटे में कुछ दो. That is very important. Nutritional formulas, however, as per guidelines नहीं सबको देने होते, but I have seen in my own experience they work quite well in many patients, especially when given in between meals. So अगर snacking के वक्त आप nutritional formula देते हो, रात को बेड टाइम पे देते हो, तो नॉक्टर्नल हाइपोग्लाइसीमिया जनरली नहीं होता या फिर प्रिवेंट हो जाता है. Sorry. So again, so clinical frailty scale. So scale अगर हम इसका देखें, the first one is very fit. People who are robust, active, energetic, and motivated. These people commonly exercise regularly, and they are among the fittest of their age. So Dara Singh at this age. Simple words. Second is well. So again, people who have no active disease symptoms but are less fit than category 1. Often they exercise or are very active occasionally or seasonally. So third is managing well. So again, as the name suggests, people whose medical problems are well controlled but are not regularly active beyond routine work. These are generally normally a general category. Again, vulnerable. So again, while not dependent on others for daily health, often symptoms limit activities. So again, a common complaint is being slowed up. That means मैं थक जाता हूँ, right? बहुत जल्दी थक जाता हूँ चलने में, या थक जाती हूँ चलने में. So ये vulnerable category, ये scale में आता है. Fifth is mildly frail. That means these people often have more evident slowing and need help in heavy older, again in finances, transportation, heavy housework and medication. So दवाई देनी पड़ती है, लेके जाना पड़ता है routine work के अंदर. Typically mild frailty progressively impairs shopping and walking outside alone, meal preparation and housework. So normal routine में उनमें progressively वो damage करता है, restrict करता है. Again, moderately frail, that means people need help with all outside activities and with keeping house. So again, inside they often have problems with stairs and need help with bathing and might need minimal assistance. Normally in सबके साथ कोई मतलब उनका बेटा या बेटी या फिर कोई nurse जो है वो उनका help करने के लिए होता है. So again, standby and dressing के लिए. Seventh is severely fail. That means जो कि dependent हो. So again, completely dependent for personal care from whatever cause. So it may be physical or it may be cognitive, Alzheimer's disease, dementia, etc. Even so, they seem stable, not at high risk of dying. So within generally those individuals who have basically severe disease or something. So again, 8 is very severely frail. That means completely dependent, approaching the end of life. Typically, they could not recover from even a minor illness. That means cancer patients हो गए, कोई extremely debility infection ailment के problem हो गए, AMS, so MS हो गया, so all those. And terminally ill, that means approaching the end of life. This category applies to people with life expectancy less than 6 months who are not otherwise evidently frail. So again, scoring frailty is in people with dementia. So again, degree of frailty corresponds to the degree of dementia over here. Common symptoms in mild dementia may include forgetting the details of recent event, through though still remembering the event itself, repeating the same question or story, and social withdrawal. Same चीज बार बार बोलते रहते हैं, same चीज बार बार करते रहते हैं, पुरानी चीजें याद रहती हैं और नई चीजें भूल जाते हैं, right? Moderate dementia, recent memory is very impaired, even though they seemingly can remember their past life events well. They can do personal care with prompting. And in severe dementia, they cannot do personal care without as simple as that. So कोई भी काम अपने आप कर ही नहीं सकते, सब भूल जाते हैं. So it's like that. Right? Normally Alzheimer's disease में होता है. Now let's look at their A1C targets. So again, as we know, so A1C less than 6.5 is adults with type 2 diabetes to reduce the risk of CKD and retinopathy if at low risk of hypoglycemia. Seventh is most adults with type 1 or type 2 diabetes. And again, 7.1 to 8.5 is 7.1 to 8% is for those who are functionally dependent. And 7.1 to 8.5 is basically for those who have recurrent severe hypoglycemia or hyperglycemia unawareness. That means hypo होता है और पता ही नहीं चलता ये hypo हो गया. ये ऐसे बहुत सारे patients होते हैं, elderly patients बहुत सारे होते हैं. Again, second is limited life expectancy, जिसमें life expectancy जो है वो limited है. Cancer patients हैं, heart failure के patients हैं, kidney failure के patients हैं. And again, frail elderly or with dementia. So again, and or dementia. Avoid higher A1C to minimize risk of symptomatic hypoglycemia and acute or chronic complications. Well, it depends on the age. As I said before, it depends on the age. So, बहुत ज़्यादा elderly patient है with these comorbidities. So higher HbA1c till 8 to 8.5 चलता है. Otherwise, we should always look for controlling the HbA1c between 7 to 8%. And of course, end of life, so A1c measurement is not recommended. One should always avoid symptomatic hyperglycemia and any hypoglycemia. That should never happen. Now, again, as I said before, so again, it's almost the repeated ones. So CG, I would say जो SMBG है pre-parental post-parental, इसके अंदर that should remain between 4 to 7 millimole per liter or 5 to 10 millimole per liter. That means around जो functionally independent है. That means between 75 to 90. And again, जो post-parental है between less than 180 होना चाहिए. That means. And again, less than 200 होना चाहिए. That means functionally dependent है. So basically around 125 to 140, and less than 12 का मतलब हो गया less than 250, less than 200 to 250 milligram per deciliter. And frail है, that means 6 to 9 millimole per liter. So around I think around 150, and post-parental would be less than around 300. And of course, end of life cancer, it can be individualized. Now, these are various guidelines. So again, guidelines recommendation for key clinical outcomes may include, so of course, we will be including ADA, Diabetes Canada, and IDF, International Diabetes Federation guidelines over there. So again, A1C is healthy ke andar, it should be less than 7.5. Just give me a second. Sorry. Healthy ke andar, it should be less than 7.5%. Again, as per the ADA, Diabetes Canada says it can be less than 7%. IDF says it should be less than 7.5%. So 7 to 7.5 के बीच में ideally होनी चाहिए. Complex intermediate अगर है patient, that means frail है और complicated है, comorbidities हैं, तो less than 8% होना चाहिए. And very complex है और poor health है, that means end of life है, that means stage 3 है, so it's like जो third category मैंने बताया था. So बहुत ज़्यादा frail है और मतलब comorbidities बहुत ज़्यादा हैं, end of life है, तो it less than 8.5 होगा without hypoglycemia, तो चलेगा. Again, frail with dementia, DC also says frail with dementia should be less than 8.5, and A1C may not be recommended. Of course, hyperglycemia and hypoglycemia should be avoided. Same goes for IDF. So again, sub-level frailty hai, so less than 8.5, sub-level dementia hai, less than 8.5, functionally dependent patient hai, so less than 7 to 8%, and end of life hai, of course, hyperglycemia, symptomatic hyperglycemia, avoid करें, prevent करें. Blood pressure के लिए देखते हैं, so less than 140 to 140 by 80 mmHg. Complex intermediate patient है with comorbidities, so again 140/80. Very complex or very poor health है किसी की, so less than 150/90 हो तो चलेगा. So again, IDF के हिसाब से भी it's 140/90. So again sub-level frailty है तो less than 150/90. Sub-level dementia है तो less than 140/90. And end of life है तो again strict BB control may not be necessary. LDL control, so lower density lipoproteins, so again less than 1.8 millimole per liter as per ADA, less than 2 millimoles per liter, and less than 2 millimoles per liter adjusted based on CV risk. So अगर कोई किसी को CV risk ज़्यादा है, so less than 2 millimoles per liter जो है वो होना चाहिए. Now again, this was a study, basically this is taken from a study. Again, done in 2016. So basically, golden versus DM scan. So this was done for elderly patients, where 50% men were taken in golden study and 54% in DM scan. So again, age was 72 and 64. Duration of diabetes around 8 years, and this was not available in golden. So HbA1c again around 7%. LDL 1.6 to 1.9 millimoles, 73 to 57%. Blood pressure was 130/70. Effectively, blood pressure less than 130/80 was 41% patients in golden and 36% patients in DM scan. And again, 19% patients had HbA1c less than 7%, LDL less than 2%, and BP less than 130 by 80 in golden, and 13% in DMHCA patients. So again, it was found that middle age पे आते आते hypoglycemia के chances ज़्यादा हो जाते हैं. So if again older, and they have a lesser perception of hypoglycemia. So as you can see, the red one, that's the middle age between 39 to 64. So so the patient had hypoglycemia, but उन patients को पता नहीं चला कि उनको hypoglycemia हो रहा था. So that's why hypoglycemia नहीं होना चाहिए. So again, healthy behavior interventions के हिसाब से there are some grades. So again, at diagnosis of type 2 diabetes, stay healthy. So there should be healthy behavioral interventions. उसमें nutritional therapy, weight management, and physical activity, plus minus metformin. A1C should be less than 1.5%. If A1C is above 1.5% above the target, less than 1.5% above the target. If A1C, then again, if not, and again it is not at the glycemic target, within 3 months, start or increase metformin. If not at the glycemic target and clinical CVD है, then various drugs आ जाएंगी. मैं आपको बताता हूँ. अगर more than 1.5% above the target, then metformin should be started immediately. अगर वो पहले नहीं चल रही थी. And second concurrent drug जो है, that can also be initiated. Again, अगर symptomatic hypoglycemia है या metabolic decompensation है, then again initiate insulin plus minus metformin. If they are not in glycemic control, या फिर किसी को ASCVD के chances ज़्यादा हैं या clinical CVD हो सकती है, कोई high risk patient है, then start the hypoglycemic agent with demonstrated CV benefits. As I said before, it's empagliflozin, liraglutide, and canagliflozin. ये demonstrated CV benefits हैं. CV safe में DPP4 inhibitors भी आते हैं और in fact glimepiride भी आता है CV safety के अंदर. But CV benefit इन्हीं drugs के साथ. अगर glycemic target पे नहीं भी हो, then again additional anti-hypoglycemic agent best suited for the individuals should be started. Clinical considerations के हिसाब से hypoglycemia हमेशा avoid करें. Weight gain with adequate glycemic efficacy भी avoid करना चाहिए. But again कुछ medicines जो है उनसे weight gain होता है. Weight neutral drugs हैं, so that can be added. Choice of agent के अंदर DPP4 inhibitors, GLP-1 receptor agonist, and SGLT2 inhibitors. These are the best drug of choice in elderly. However, SGLT2 inhibitors में एक complication होती है जो कि elderly में ज़्यादा हो सकती है. कौन बताएगा? Using SGLT2 inhibitor, there is one complication which we should always keep in mind. Who will tell me? Can anyone tell me?
Fournier gangrene.
Fournier gangrene or मंजुनाथ?
Pancreatitis.
Pancreatitis क्यों होगा यार SGLT2 में?
Rare side effects sir.
Pancreatitis क्यों होगा? जब किडनी पे जाके काम कर रहा है वो?
Balanitis होता है. Yes.
क्या होता है?
Balanitis is the complication. Balanitis.
नहीं sir, euglycemic ketoacidosis.
SGLT2 complication balanitis.
ठीक है. Okay.
Euglycemic ketoacidosis.
ठीक है, बिल्कुल ठीक है. देखो सबसे इम्पोर्टेंटली UTI है. यूरिन इन्फेक्शन होगी यार. पहले यूरिन इन्फेक्शन तो देखो. So elderly patient है, ध्यान नहीं रखता, prostate बड़ा हो सकता है तो UTI होगा ना पहले. So उसका that is the most common complication. बाकी सब उसके बाद आती है. ठीक है. चलो उसके बाद other considerations में again reduce GFR और albuminuria, clinical CVD or CV risk factors, degree of hyperglycemia, other comorbidities is CHF, hepatic disease, planning for pregnancy, cost coverage and patient preference. And again now ये सारी recommendations हैं. So again Again, add additional hypoglycemic agent which is best suited for. I'm sorry guys, वो background music कावड़ियों का है, so I'm sorry for that. So again, add additional anti-hypoglycemic agents best suited for individuals for prioritizing patient characteristics. So again, one should keep an effect of CVD outcomes, hypoglycemia, weight, relative A1C lowering when added to metformin, and other therapeutic considerations, and of course the cost. So GLP-1 RAs, they are superiority in type 2 diabetes management, but again, and for clinical risk factors, hypoglycemia is rare, HbA1c reduction is good. The effects are majorly GI side effects, gallstone disease, and they are of course contraindicated in personal family history of medullary thyroid cancer or MEN2. And of course, it has to be given injectable. However, अब semaglutide आ गया है and we are using it, so injectable injection देने की problem जो है that is now over. But of course, the cost. So cost is a major problem with this drug. It's the costliest drug available for diabetes, so that again is a problem. SGLT2 inhibitors, again, CANA and EMPA has superiority in type 2 diabetes management with patients with clinical CVD. Hypoglycemia rare होता है, weight gain होता नहीं, weight loss होता है, and HbA1c lowering is almost equivalent to GLP-1 analog. Again, as I said, genitourinary infections, UTI, hypotension, dose-related changes in LDL can be there. अगर आपका पेशेंट डाययूरेटिक्स पे है, प्लीज अगर आपका पेशेंट डाययूरेटिक्स पे है या उसके रीनल डिस्फंक्शंस हैं या वो एल्डरली है, सो प्लीज ध्यान रखें SGLT2 की डोज मॉडिफिकेशन हो सकती है या इन ड्रग्स की डोज मॉडिफिकेशन हो सकती है. Dapagliflozin is not to be used in bladder cancer, and rare diabetic ketoacidosis, euglycemic ketoacidosis, as you said, may happen. Increased risk of fractures and amputations with canagliflozin was basically found in Canvas trial, and again reduced progression of nephropathy and CHF hospitalizations with empagliflozin and canagliflozin in those with clinical CVD was clearly evident. DPP4 inhibitors, Alosexa, Sita, Lina, they are cardio neutral drugs or cardio safe drugs. हाइपोग्लाइसीमिया रेयर है, जनरली नहीं होता, बहुत रेयर है. न्यूट्रल ड्रग्स हैं, वेट न्यूट्रल ड्रग्स हैं, एक्सीलेंट ड्रग्स हैं. एंड अगेन साक्साग्लिप्टिन, एज आई सेड, हार्ट फेलियर की कॉशन है, जो बेसिकली उसमें दैट नीड्स टू बी अवॉइडेड इन पेशेंट्स विद ASCVD एंड दोज विद हाई रिस्क ऑफ हार्ट फेलियर. हम लोग जनरली अब यूज नहीं करते. Insulin, again, glargine, degludec, and U100, U100, U300, U100, U300, and degludec U100. Again, hypoglycemia हो सकता है. It's an insulin. However, पुरानी insulin से इनमें कम होता है comparatively. It's weight gain. Weight gain भी generally कम होता है as compared to पुरानी insulins. And of course, HbA1c lowering, as we all know, it's insulin. It has to bloody reduce the HbA1c at all levels. Dose ceiling कोई है नहीं. So again, we can generally start with the newer ones. We can start with 0.2 units per kg body weight. पुरानी वाली 0.1 से भी देते थे या 10 units से start करते थे, which was again an older method. We generally use 0.2 units start with 0.2 units per kg body weight and can up till and probably can go up till 0.8 units per kg body weight. Also, upper cap होती नहीं है, but उससे ज़्यादा generally basal bolus पे आ जाना चाहिए. Of course, it requires subcutaneous injection. TZDs is it has a neutral CVD outcome. However, those patients who are at a higher risk of fluid overload, उनमें generally avoid करते हैं. Again, hypoglycemia भी rare है. It's not very common. Weight gain होगा generally. And HbA1c जो है वो relatively mild to moderate है. CHF, again, as I said, fluid overload हो सकता है. So CHF, edema, fracture, and rare blood cancer with pioglitazone. Cardiovascular controversy, rosiglitazone की जो हुई थी, इसकी वजह से drug ban हो गई थी. and 6 to 12 weeks for minimal effect. Maximal effect can happen. AGIs again rare है, hypoglycemia बहुत ही हल्की दवाई होती है, हल्के ड्रग्स हैं, so again weight neutral drugs हैं, and actually सबसे हल्के ड्रग्स इन सब में जनरल यूज में यही हैं. GI side effects are very common, so requires 3 times daily dosing, चाहे acarbose हो चाहे voglibose हो, similar kind है. Insulin secretagogues, meglitide and sulfonylureas, again hypoglycemia तो होगा because they are pushing pancreas to work more, weight gain भी होगा, and again A1C lowering जो है that is moderate. Again more rapid BG lowering response, reduce postprandial glycemia with meglitide, but usually requires 3 to 4 times daily dosing. Glyclazide and glimepiride are associated with less hypoglycemia than glimepiride, and they have poor durability. Weight loss agents जैसे कि orlistat है, उसका भी थोड़ा बहुत माइल्ड A1C lowering या ग्लूकोज लोडिंग करता है. वेट लॉस की ड्रग है, सो वेट लॉस ही करेगा और कुछ करेगा नहीं. एंड अगेन GI साइड इफेक्ट्स होते हैं बिकॉज डायरिया करता है कई बार, एंड अगेन रिक्वायर्स 3 times डेली डोजिंग. सो इफ अगर इनके ऐड करने के बाद भी ग्लाइसेमिक टारगेट अचीव ना हो, then add another anti-glycemic agent, या फिर बेटर बेस्ट यही होता है कि 3 ड्रग्स के बाद you generally intensify with insulin regime. Make timely adjustments to attain target A1C levels within 3 to 6 months. देखो एक बात हमेशा याद रखना, कोई भी पेशेंट हो किसी भी कैटेगरी का, जितनी जल्दी A1C टारगेट अचीव करोगे, जितनी जल्दी हाइपोग्लाइसीमिया प्रिवेंट करेंगे, उतना ही उसको ओवरऑल होलिस्टिकली बेनिफिट मिलेगा, चाहे उसका हार्ट हो, चाहे किडनी हो, चाहे ओवरऑल हेल्थ. सो A1C टारगेट within 3 to 6 months, we should try to at least reduce it by at least 1%, 1 to 2%. Now again, renal functions के हिसाब से that is very important in elderly patients. So renal functions के हिसाब से there's again 5 stages as we know. So stage 1 जिसमें आपका GFR more than equal to 60 or 60 to 90 होता है. Stage 2 जिसके अंदर 60 से नीचे more than 60 होता है. Stage 3A जिसमें 45 to 59 होता है. Stage 3B जिसमें 30 to 44 होता है. Stage 4 जिसमें 15 to 29 होता है. और Stage 5 which is ESRD जिसमें less than 15 होता है. So again AGIs आप दे सकते हो till stage 3B, Bigonides, metformins till stage 3B तब दे सकते हो. Actually 45 के नीचे recommendation नहीं है, so लेकिन up till 30 या 500 milligram से 1 gram तक दे सकते हो, but try to avoid Bigonides, giving Bigonides less than 45 GFR. Allogliptin जनरली यूज नहीं करते, बट फिर भी आप 60 के नीचे डोज रिडक्शन होती है. लीनाग्लिप्टिन आप जिस मर्जी डोज में दे दो, इनफैक्ट 15 से भी नीचे भी आप दे सकते हो. ESRD के पेशेंट्स में भी लीनाग्लिप्टिन देते हैं. साक्साग्लिप्टिन नहीं देते, लेस देन 30 हम नहीं देते, बट 2.5 मिलीग्राम पर डेसीलीटर पर डे के हिसाब से आप दे सकते हो. अगेन सीताग्लिप्टिन सो बड़ा सिंपल है, 50 से नीचे हो हाफ कर दो, 30 से नीचे हो 1 quarter दे दो. GLP एनालॉग्स 30 के नीचे नहीं देनी, 50 के नीचे दे सकते हैं. लीराग्लिप्टाइड अप टिल 15 हम दे सकते हैं. लिक्सिजिनाटाइड 30 तक दे सकते हैं. ग्लाइक्लाजाइड, ग्लिमिप्राइड एंड ग्लिबुराइड 30 तक दे सकते हैं. जनरली वी शुड अवॉइड गिविंग सल्फोनाइलुरियाज बिलो 45. Again rapaglinide हम it's a short acting drug, so less than 60 हम दे सकते हैं. Canagliflozin less than 40 till 45, dapagliflozin till 60 and empagliflozin till 45. अब DAPA CKD trial के बाद we can even give it at till the GFR of 30, but as per guidelines it should be avoided more than if the GFR is less than 45. पाइग्लिडाजोन रोजिग्लिडाजोन हम देते नहीं, इंसुलिन आप जिस मर्जी पे दे दो, पाइग्लिडाजोन टिल 60 दे सकते हैं, उसके नीचे नहीं देते।